In this section, I will talk about failed spinal anesthesia. Now, failed spinal anesthesia could be unsuccessful attempt of giving spinal anesthesia, or it could be that we have given the spinal, but the required level of block or has not been achieved. A block is patchy, or block is inadequate, or there is no block in spite. It seemed that the procedure was successful. So both comes under unsuccessful spinal anesthesia. So let us talk about the failure of spinal anesthesia under two headings. The first thing which I would discuss with you is that unsuccessful attempt. So what could be the cause of unsuccessful attempt? Now, there is a lot of cause in for unsuccessful attempt, and most of it can be modified by a proper technique. Most of it is modifiable with proper check and proper technique. So we'll talk about unsuccessful attempt and what are the troubleshooters. How can we prevent that unsuccessful attempt and make it successful? And the second could be the failed block. That is, I had given the block, but the block is failed, and this could be due to multiple reasons: inadequate spread of the drug, or drug problems, the wrong drug, or inadequate volume of drug has been used, or drug has been lost during the injection into the subarachnoid space. Number of things can cause failed block. And how can we remedify it and how can we manage it, we will discuss. So let us first discuss that what are the causes of unsuccessful lumbar puncture or unsuccessful spinal anesthesia. What do I mean by this? Inability to reach the subarachnoid space. So unsuccessful means our inability to successfully reach subarachnoid space. Okay. Now, what could be the reason for this? There could be multiple reasons for this. So, number one, while giving the Neuraxial blockade and to go through the interspinous space, a proper patient positioning is required. So, maybe the patient position was not adequate. So, poor patient positioning. Now, let's say the patient positioning was fine, but the technique of needling was not proper. So, incorrect needling technique. Now, let's say the needling technique was also correct, but anatomical factors. Now, patient had some spinal deformity, or maybe apparent deformity was not seen, but some anatomical factor causing the issue. So, anatomical abnormality could be the cause, and your equipment failure related issue. Now, equipment could be faulty, or equipment was not checked properly, whatever. So, first two, the poor patient positioning and incorrect kneeling technique, both are pretty modifiable, and these are modifiable, and we can rectify these faulty techniques simply by having a good assistant. So, proper patient positioning and proper needling technique we will discuss. The equipment related issue, this can be prevented by a practice of proper equipment check every time before we are giving the spinal. So, I'll talk about it. And anatomical abnormality, like your patient having kyphosis or patient having scoliosis, right? We just need some level of experience to give spinal in these patients, right? Maybe in the patient with anatomical deformity, the ultrasound technique can be of great help in reaching the space, in knowing the depth of the space, knowing where is the interspinous space, right? So, here ultrasound can be a very good help. So, let us first discuss that equipment related issue which can lead to the failure. Okay. So, equipment related issue. Now, this can be mitigated by the right practice. This can be mitigated by right practice. practice. So what is the right practice? The right practice is that always check your equipment before attempting the procedure. So the right practice is, number one, we need to check the equipment. So we have to check the equipment, right? Equipment has to be checked. Number two, that let's say normally, let's say I have checked the equipment, the lumen of the spinal needle is fine. Normally the lumen gets blocked when we are attempting the procedure, and the most important reason of blocking is that number of time what we also see people while performing spinal remove the stylet and manipulate the needle. So try to keep the stylet always inside the needle. That will prevent the blockage of the needle by any let's say blood particles, etc. So lumen getting blocked during procedure, lumen getting blocked during procedure, right? So this can also happen. So what should we do? We should always keep stylet on while the needle is getting advanced. So keep stylet when needle is advanced. So never manipulate the needle without the stylet. The number of time it seems that we are with let's say stylet was there, and it seems that we are in right place, and then also the CSF after removal of stylet is not coming. In that case, we have to remove the needle immediately and do the flush test, right? We have to flush the needle and check. So if it seems right space but no CSF, so then we have to remove the needle and perform flush test. Okay, so this is what we have to do. We have to check it. Okay, now modifiable problems. Now this can be, the equipment related issue can be solved just by doing the right practice. Now the other modifiable issues, that is poor patient positioning. Now we should have a very good assistant who could help and who could encourage the patient to make a proper position. So what are the position which is made during neuraxial spinal anesthesia? Most commonly sitting and the lateral. Prone can be done, but normally at most of the centers it is not practice. It is mostly sitting and lateral position. So mostly it is sitting and lateral position. So if you ask me which is the better one, well, it is personal preference. In whichever position you have been trained and whichever position you find better, that's the preferable position. So it's a personal preference. But what has studies shown, that in patient in whom it is difficult to identify the midline, the obese patient, etc., the sitting would help us in better identifying the midline. So in obese patient or patient in whom it is difficult to identify, midline, sitting position is considered better by most of the study. Sitting is considered better. Now when you are making a lateral position, certain tips to the patient, that touch your elbow to your knee and let's say flex your neck, your hip joint and your knee joint, all this would help us in giving a very good interspinous space. So when the person is in lateral position, simple tip, like we have to flex the neck has to be flexed, then spine has to be flexed, knee has to be flexed. Now for this we can just ask the patient to touch his elbow or her elbow with the knee joint. That would give us a very good position, and good assistant help has a great role to play. So if I have a good OT technician, a good one, then it would be not my headache to make the position of the patient. So good assistant is very helpful, Okay, so position should be very optimum and it should be the routine practice to always make a proper insertion. Now, needle insertion. Now, for spinal anesthesia, we all know that in an adult, normally that spinal cord end at the lower border of L1. So, we attempt spinal at L2, 3, L3, 4. Below that lower border of L1 was the L2, 3, L3, 4 are the interspace which we are going. Now, how do we mark the interspace? How do we reach the interspace? Now, there are various ways. Now, some surface landmark method is that we palpate the anterior superior iliac spine of both the side and intercrystal line between anterior superior iliac spine that falls in between L3, 4 space. That's called Tuffier's line. So, intercrystal line or Tuffier's line fall between L3, 4 space. This is the line between anterior superior iliac spine of the both side. Now, how do we advance the needle and how do we troubleshoot if we come across the bone? The interspinous space, we have to go midline in the interspinous space, and we should not encounter the bone in midline if our technique is proper. So, when we are attempting the spinal anesthesia, right, we have to go perpendicular initially. If we encounter the bone, then only we have to change the position of the needle. So, it's number of time I see the people going in the cranial direction when they are inserting the needle. No, first we need to go perpendicular. That this approach has been said to be the best approach. So, needle should be perpendicular. It should be perpendicular to skin in both planes, and we should advance it cautiously, slowly. Now, fine adjustment we will do when we encounter the bone. Normally, mostly cranial adjustment is done. So, fine adjustment according to the difficulty. So, what are the difficulty we can face? So, if needle hits the bone during spinal needle placement, we have to note the depth, at what depth the bone has been encountered, withdraw the needle into the introducer and redirect and reinsert in slightly cephalad direction. So, we have to withdraw the needle till skin, till the introducer, and then we have to make the direction slight cephalad. If the bone is contacted again, then redirect as, now I will tell you as we follow. Initially, when we are going perpendicular and I encounter a bone, I withdraw the needle to the skin, or let's say into the introducer, and then with a little fine tuning in a cephalad direction, I will again go with the let my needle go. If I again encounter a bone, then what should we do? If bone is contacted at a shallow depth, it is just I am introducing the needle and I am getting the bone, it is most likely that the cephalad spinous process is coming in contact, right? So, cephalad spinous process is what we are hitting. So, we should withdraw the needle, and now the needle should be more corded, little corded. So, initially we are going perpendicular, right, and if I am hitting the bone repeatedly, even on making my little needle cephalad, and again at the shallow depth I am again hitting the bone, then it's most probably the upper spinous process is what I am hitting. It is at the shallow depth. So, I just have to make my needle little corded. So, we have to redirect the needle in a corded direction. If the bone is contacted deeper, the needle is more likely contacting more corded spinous process that will come at a deeper level. So, in that case, needle should be redirected even more cephalad. So, even more cephalad we have to redirect the needle if I am encountering the bone at a depth. If bone is contacted just as I am inserting at the same depth, needle is most likely repeatedly at the same depth, the bone I am getting. So, it is most probably contacting the lamina and the tip is off the midline. So, what we need to do, it's most probably we are hitting the lamina. So, we have to again feel for the midline, the interspinous space. So, midline should be reassessed and it will be redirected accordingly. Patients can often report that they perceive the needle on one side or other. So you can ask your patient also that, are you feeling that needle is going in midline? So just image. So this is the correct position. So if I'm encountering the bone right at a shallow depth, it is the cranial interspinous space, that cranial spinous process that we are hitting. So we just have to change the direction of the needle caudad. If I am contacting the needle at a depth, then it is mostly the caudad spinous process, right? This is the spinous process, right? If immediately after putting the needle I am hitting, it is the cranial spinous process. So I have to take the needle in a more caudad direction. If I am facing the bone at a depth, it is the caudad spinous process, spinous process. So again, I have to make the direction of the needle more cranial. I have to make the direction of the needle more cranial to come in this interspinous space. Okay, if I am coming across the needle, right, at the same depth, I am coming across the bone at the same depth, it is most probably the lamina I am hitting. So maybe I am away from midline. So again, I have to reassess the midline. So we have to fine adjust the needle. Now repeatedly, in case of anatomical difficulty, like if patient has kyphosis, scoliosis, any anatomical difficulty, right? So kyphosis, scoliosis, the use of ultrasound can be very helpful. How can ultrasound help us? A pre-procedural ultrasound can help us and tell us about the midline. We can mark the midline, and we can also take the help of ultrasound and know the depth in which the subarachnoid space we will get. So we can assess the depth. So we can take the help of ultrasound. So ultrasound can be very helpful. Ultrasound will tell us two things. It will tell us the midline. It will help us in identifying the midline, and it can also help us in assessing the depth of subarachnoid space, right? So in difficult, I would always go do a pre-procedure. During the procedure, with ultrasound, it is practice which is not mostly practiced at most of the institute. Pre-procedural ultrasound is much more helpful. Okay, now pseudo-successful lumbar puncture. Now this is a very tricky thing. I think that lumbar puncture is successful. I am getting a return of CSF, but it is not CSF. This could happen rarely in some condition. If patient has a epidural catheter before, and you have given a top of really just little time while ago, the collected drug can come as can appear like CSF. So what we can do? We can do a bedside glucose test and identify whether it is CSF or a drug. Or sometimes, very rarely, there is a cyst which can be present in the subarachnoid space, just outside the subarachnoid space, and we can hit that cyst, and the collection of the fluid collected in the cyst, the clear fluid is coming, that we misinterpret as the CSF. So clear fluid, but it is not CSF. So we are getting a clear fluid of non-CSF origin. Now, number of time, this can be due to, number one, drug collected in epidural space, and for this we can do bedside glucose test, right, of CSF. The glucose would be in the, sugar would be in the CSF. Or there is a rare cyst, that is Tarlov cyst, that is the meningeal dilatation. This is meningeal dilation of the posterior spinal nerve root. So this is present in 4.5 to 9% of the cases, and this is a rare thing, and fluid collected in this cyst can come, and we can misinterpret it as a CSF. So this can be a little tricky position, very difficult to diagnose as such. Okay, now let's talk about that. I have given the spinal, I reached subarachnoid space, I gave my drug, volume and whatever drug I wanted to give, but then also I am not getting the effect. So we call it now failed spinal. Failed spinal. So successful lumbar puncture, right, has been given, but still the failed spinal. Successful lumbar puncture is definitely a requirement for a subarachnoid block, but it does not give us a guarantee for a successful subarachnoid block. So it's a possibility that in spite of successful lumbar puncture, we would not get a required block, and we would put it in the category that the block has failed. So what are the reasons for failed block? There are multiple reasons for the failed spinal. Now, could be the drug issue, could be, let's say, the positioning issue. After giving the drug, the proper positioning of the patient was not done. Could be the anatomical issue, right? So it could be drug issue, right? It could be the positioning issue. It could be the anatomical cause issues causing it, right? So there are a number of issues. So drug issues, let us first talk about the drug issues. Now, maybe I chose the correct drug. The drug was indeed our local anesthetic which we intend to give, but the volume which I had chosen was not proper, and that did not produce the adequate level of the block. So how do we select the dose of the drug in spinal? What are the factors which help us in selecting the dose? So as an anesthesiologist, we should know our drugs nicely. What is the onset of action of the drug? What is the duration of action of the drug? What is the procedure for which we are giving the drug? Indeed, we need to choose the drug accordingly. So first is the choice of drug dose is on the basis of what local anesthetic we are using. Local anesthetic used. Then what is the baricity? It's a hypobaric, isobaric, or a hyperbaric drug. So baricity of the drug, that it is iso or it is a hyperbaric. Then it depends upon that what is the patient's positioning. Then what is the duration of the block required? And definitely patient's comorbidity, how much at most care we have to take. So patient's comorbidity also should be kept in mind. Number of time giving a small volume of drug also would produce an adequate level of block and would not cause any hemodynamic imbalance, and that would be more suitable for some particular patients, right? Okay. Now, the studies have shown that volume of drug has not affected the level of spinal anesthesia. More or so, the volume is dependent the duration of the spinal anesthesia. So volume is more affecting the duration, and the other factors are more affecting the level, that is the baricity of the drug, right? The baricity of the drug is more affecting the level. Now the local anesthetic which you are using, so these are more affecting the level, but the volume which you have used is more affecting the duration. So more the volume, if duration has to be required is more, if the surgical procedure is longer, right? Okay. Now the other issue can be the loss of injectate. I chose the correct dose according to the procedure, according to my patient, everything fine, but while injecting, the drug was lost. For subarachnoid block, a very small volume of drug is used, 2 ml, 3 ml. And if you even lose a 0.2 or 0.4 or 0.3 ml, that would be a substantial loss. So, loss of injectate. So, leakage may occur at Lure connection, that is connection between the needle hub and your spinal needle. So, at the Lure connection. Now, small volume is used, as I said. We use a very small volume. So, we have to see that there should be no leak, right? Loss of injectate should not happen, right? So, how should I fix it? How should I fix my, when I am injecting the drug? How should I fix the needle? Number of time we aspirate and we check whether the CSF is coming or not after connecting the needle, the syringe to the spinal needle. So that is one of the most common point, let's say, time at which the malpositioning of the needle happens. The needle gets little pushed or needle gets little pulled, and that causes malpositioning of the needle. So we have to be very careful and gentle while we are doing this check and all. And any time when you are checking, etc., your palm should be on the back of the patient and your thumb and the other finger should be on the hub of the needle to keep it there in a balanced position, and not let the spinal needle go, not let the spinal needle get misplaced from its position, right? So proper stabilization of the needle is must. Okay, so what will happen if this needle which we are using for spinal anesthesia moves? Now there are a number of things which can happen, right? So we are using small volume. We should permit no leak. We should have no leak. Now what happens that if the needle, what is the correct placement of the needle? You can see this, the needle most commonly which we are using is nowadays dura splitting needle, and the misplacement is more common with the dura let's say not dura cutting needle but dura splitting needle, because these are pencil tip needle and the opening for the drug delivery is in the side wall. So let's say this is the correct position. In the needle, the entire opening is inside the subarachnoid space. Well, needle got little misplaced. The CSF is coming because half the needle, the opening is in the subarachnoid space, but other is outside the subarachnoid space. So here I am getting the loss of drug. Number of time, there is a, let's say, a closed valve kind of thing happen because of the dura mater. Dura mater creates a valve on the needle, and when we are injecting the drug, because of this valve which is preventing the drug to go into the subarachnoid space, the drug goes into subdural space. Okay, the subarachnoid space, the needle is in subarachnoid space, so the CSF will come when we will aspirate. But when I am giving the drug, okay, this meninges is acting as a valve and not letting the drug to reach subarachnoid space. The drug would be lost in subdural, or drug would be lost in subdural or epidural space. So loss of drug will again happen. So there is always a possibility of small that leak is possible if we are not fixing our needle in a proper way, right? So we have to fix our needle in a proper way. A lot of time even the new residents at the lure where they are fixing the syringe with the spinal needle, there only some leak of the drug happens. That should also we have to take care of. We have to very visibly, we have to inspect everything what we are doing. Okay, so what are the precautions that we can take to prevent this loss of inject and see that where we are in the space or not? So for what we can do, that aspiration of CSF once we are in subarachnoid space, 0.5 to 1 ml before injection of drug. So this would say we are in subarachnoid space. We always fix and then we aspirate, right? Then aspiration of CSF 0.5 to 1 ml at end of spinal injection, So at the end of the procedure also, you check very gently and re-inject what you have aspirated. So the aspirate should be re-injected. So aspirate should be re-injected. So you have to be very careful. Aspirate when you start the giving the drug, aspirate at the end, and re-inject the aspirate back into the subarachnoid space and then take the needle out. So this will assure that your needle was throughout in the subarachnoid space and you have not lost the drug, right? So this is important for proper preventing the loss of drug. Okay, the next thing which can happen is inadequate spread of the drug. Now this can be due to the drug which you are using, isobaric, hyperbaric, the anatomical difficulties. So this could be due to anatomy, this could be due to anatomy, this could be due to the physical property of the solution, physical property of solution, and this could be due to gravity because the drug which you are using, right? Gravity because of the drug which you are using. So what could be the possible anatomical issues? Kyphosis, scoliosis, the studies have shown in them there is a chance of inadequate spread of drug. So anatomy, abnormality like kyphosis, scoliosis, right? So this can lead to inadequate spread of the drug. Now, number of times the anatomy of spine seems fine, but some fascia or the septate inside the space, the ligamental barrier, they can prevent the spread of the drug. So ligament can cause barrier to the spread, or septate present in the space can cause barrier to the spread of the drug. So these are the things that we cannot modify. It is something which we are not even getting to know, right? Then the